I'm Carrie Pallardy, an editor with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. John Bartos serves as the President and CEO of CollectRx. Mr. Bartos is a veteran in the field of healthcare and information technology. As President of Dr. First and Executive Vice President of Primatics, Mr. Bartos is specialist in providing cost containment services to health insurers and various products and services to hospitals, health systems, and other healthcare providers. Previously, Mr. Bartos was an attorney at Kirkpatrick and Lockhart, now K&L Gates, where his practice focused on litigation. It is now my pleasure to turn the floor over to John to begin today's presentation.
Thank you, Carrie. I appreciate that. Hello, everyone. My name is John Bartos, and I'm CEO of CollectRx. Despite our name, we're not a collections agency, we're not a billing company, and we have nothing to do with the pharmaceutical industry. Simply, what we do here at CollectRx is help providers get higher reimbursements on out-of-network bills, and we do so by increasing the rate of reimbursement on a bill-by-bill basis. We don't do this as consultants, but as experts in negotiating reimbursements one case at a time. Think of us as your prescription for higher out-of-network payments. During today's presentation, we'll be talking about the hidden opportunity to significantly increase profits by maximizing your out-of-network reimbursements. Specifically, I'll be talking about why out-of-network is important, the tactics used by insurance companies to reduce your reimbursements on these bills, how you can combat those tactics to maximize your out-of-network reimbursements, and finally, of course, I'll wrap up by talking about why you might want to use us to help. With respect to the opportunity, let's face it, as providers survey the landscape today, candidly, there aren't many opportunities to improve reimbursement rates. In-network contracts are what they are. There's limited, if any, opportunity to increase those rates. Similarly, Medicare and Medicaid reimbursement rates are what they are as well. But out-of-network represents the last great opportunity for many providers to bring more dollars in the door to improve the bottom line. Before I start discussing the opportunity to increase revenue significantly through higher out-of-network reimbursements, let me spend a couple of minutes explaining who we are and our expertise and experience in this area. We have specific, deep expertise in out-of-network reimbursement accompanied by sophisticated data and analytics that help us get higher reimbursements for our customers on out-of-network bills. Now, we're the only company in the country that is focused solely on helping providers get higher reimbursements on out-of-network bills. Because of our results, we've grown to over 1,200 customers throughout the country since we opened our doors in 2006. We work with a variety of different providers, including surgery centers, surgical hospitals, ASC management companies, hospitals, and physician provider groups. Next slide, please. Okay. A big reason these folks turn to us is our team. We have a team that includes physicians, former hospital CFOs, and inside and outside legal counsel, all of whom have 15-plus years dealing specifically with out-of-network bills. CollectRx was founded by Dr. Greenberg, a physician with a Wharton MBA who spent the last 30 years on the business side of healthcare. In 1991, he founded a company called About Health, which was the first to work on behalf of the insurance industry, showing them ways to reduce their payments to providers on out-of-network bills. And in 1999, he sold About Health to his largest competitor, which then became part of Viant and then Multiplan. He left the business in 2000, started CollectRx 6 years later to provide the same type of expertise to healthcare providers. In building the team here at CollectRx, Dr. Greenberg brought with him several senior executives and negotiators who previously worked with him at About Health, Viant, and Multiplan. In terms of my background, as you just heard, I'm a lawyer by training. I was a litigator at K&L Gates, one of the nation's largest law firms. And in addition, I specialize in working with companies focused on cost containment services to payers, as well as a variety of products and services on the provider side. Another team member you see here is Sonny Bloom. He's the company's president. He's an engineer by training and has a Harvard MBA. He was the chief operating officer with Dr. Greenberg at About Health, and after the merger ran the operations at Viant until 2006. And over the years, we've built a team with deep experience and understanding with the insurance companies, negotiation vendors, and repricing vendors do to lower your out-of-network reimbursements. That expertise comes from having worked for these organizations and knowing the soft spots, so to speak, to push to get higher reimbursements on out-of-network bills. Part of our secret sauce is the depth of our knowledge of how out-of-network reimbursements work from the insurance company's perspective. Next slide, please. Okay. Another key to our success is what we call our CRXIS Business Intelligence Engine, CRXIS standing for CollectRx Information System. This is a data and analytics tool that we've developed to counteract the payer's efforts to reduce payments on out-of-network bills. It allows us to do things like analyze actual policies from insurance companies throughout the country to determine what's reasonable and customary, provides us with an incredible amount of comparable data because we aggregate data and results from the hundreds of customers we work with, and we use data and analytics to compare our determination of reasonable and customary with the payers, and in many cases we're able to find holes in their data and convince them to make a higher payment. And our database captures business intelligence about the tendencies and trends of the folks on the insurance company side. So our engine, if you will, combines all of this information to suggest best case results. Next slide, please. So in summary, how do we do it? We take your out-of-network bill, run it through our CRXIS Business Intelligence Engine, then apply our expertise in handling these claims to get more money for you. Next slide, please. So I go to a lot of conferences, I read a lot of industry publications, and as I read and hear what some folks say about out-of-network reimbursements, I'm continually surprised at how often people either have it half right or not right at all. And I'm also surprised that more providers don't do more to take advantage of the opportunities with out-of-network reimbursements to bring more money in the door. Next slide, please. Despite the naysayers, providers can and should make out-of-network an important part of their revenue enhancement strategies. The reason? Patients demand choice, provider choice. Patients will see the providers they want to see, and that basic demand is not going away anytime soon. Next slide, please. This demand has fueled the out-of-network industry. Today, there are more than $60 billion of out-of-network claims each year, which has remained relatively the same for the past several years. The market is this big despite the efforts by insurance companies to reduce out-of-network reimbursements. Next slide, please. At the same time, we've seen a growth in PPO enrollment. Next slide, please. Most out-of-network bills come from PPO members, and PPO enrollment has more than doubled as HMOs have declined. Here you can see that it's gone from 27% in 1993 to 66% in 2013. And statistics show that 10 to 20% of PPO members will have an out-of-network experience each year. Next slide, please. The Affordable Care Act will promote the growth of out-of-network patients also in a couple of ways. Next slide, please. It's our view that with the implementation of the ACA, the number of insureds with out-of-network benefits will rise, and let me talk about the two reasons why that is. As of mid-last year, the number of individuals who had picked a health insurance plan from the ACA marketplace was over 10 million. While the policies do vary, and all plans aren't necessarily friendly towards out-of-network care, nevertheless, a portion of those sign up have out-of-network benefits. And given the fact that most of these people signing up were not previously insured, by definition, the fact that they are now getting insurance means that it'll increase the number of insureds that seek out-of-network care. But not only will we see an increase in patients with out-of-network benefits for this reason, we will also see an increase in out-of-network care because of narrow networks and as they accelerate under the ACA. Next slide, please. So what's a narrow network? A narrow network is a health insurance plan that places severe restrictions on providers available to their insureds. While narrow networks were already on the rise prior to the adoption of the ACA has accelerated this growth. Narrow networks put limits on insureds by charging higher patient responsibility for care provided outside the network. However, for the most part, they don't prevent patients from seeing these providers. As such, these narrow networks will result in there being more out-of-network care. Again, simply by definition, you'll have fewer providers that are in-network, making it even more important to be able to handle out-of-network issues. Next slide, please. But the ultimate and by far the most important reason out-of-network will remain strong is that people want to have out-of-network benefits, are willing to pay for out-of-network benefits, and insurance companies are left with no choice but to offer a solution to those problems, that is, policies that have out-of-network benefits. The only way out-of-network is going away is if all doctors decide, hey, we're going to go in-network. But patients just won't let that happen. They'll continue to demand those policies with out-of-network benefits. Next slide, please. So now let's move to show you how you can maximize out-of-network reimbursements in today's environment. Next slide, please. To be clear, despite insurance company efforts to minimize out-of-network reimbursements, on average, out-of-network reimbursements are close to double in-network reimbursements. Next slide, please. Even though reimbursements on out-of-network bills are higher than in-network reimbursements, there's still a tremendous opportunity to get even higher reimbursements on out-of-network bills. For example, the typical surgery center that utilizes our services, after taking our fee into account, we generate just under $130,000 per year on average, which is about $11,000 a month, in additional out-of-network payments from insurance companies. And again, this is an average. For many surgery centers, it's much higher. The key is to invest. Invest in the people, invest in the resources, invest in the data, invest in the process, and do all those things to take advantage of this out-of-network opportunity. Next slide, please. So a little bit of history here. Back in the good old days, so to speak, which was before 1990, out-of-network bills were paid at full bill charges. Next slide, please. Today, payers are using a variety of tactics which allow them to reimburse providers at between 20 and 50% of charges. But if you know what you're doing, you can improve these results considerably. Next slide, please. There are two strategies that are being used by the insurance companies to minimize your out-of-network reimbursements. One way to sort of look at these strategies is to think of it as an economist would. You have in the first, under number one, the micro-level strategy, where bills are minimized on an individual bill-by-bill basis. Then you can look at it from sort of the macro view, which is the second point here, the macro-level strategy, where bills are subject to different types of global discount agreements. Next slide, please. So let me start by talking about the micro-level strategies first. On a bill-by-bill basis, payers will attempt to minimize reimbursements by either negotiating single-case rate agreements at reduced amounts, or alternatively, repricing bills using a usual and customary reduction. Let me explain both in more detail here. Next slide, please. The negotiation situation occurs when the insurance company sends a fax to the provider attempting to negotiate a settlement of an out-of-network bill. In other words, the insurance company contacts you to negotiate a large discount after services have been provided, but before any payment has been made. Next slide, please. The UCR repricing occurs when the insurance company reprices the out-of-network bill down to what they consider to be reasonable and customary, which is typically close to the Medicare rate. They send you a payment along with an EOB, and from the insurance company's perspective, after the bill is repriced, the insurance company has satisfied its obligation and there's nothing more to be done. So the key difference between the negotiation and the UCR repricing situation is whether payment has been made. If no payment has been made, it's negotiation. If a payment has been made, it's been repriced, a UCR repricing, so to speak. Next slide, please. To understand which approach the insurance company will take, it's necessary to understand how out-of-network bills are processed. The process starts with the provider generating an out-of-network bill. It then goes to the insurance company, who transfers it to one of the vendors we talked about before. The bill then will either be subject to negotiation or it'll be repriced. How that decision is made is the key. So let me explain how that works. When an insurance company sells to an employer group, the employer group has the ability to dial up or down the out-of-network benefits. There's a basic trade-off here, a trade-off between employee discontent and the payment of premiums. The higher the premiums, the lower the discontent. The lower the premiums, the greater the discontent. And this holds true for self-insured plans where the where the issue the employer is laying out the actual claim payments. These dials come at different levels. First, does the payer negotiate settlements, and if they do, at what level? Second, what's the maximum allowed amount when bills are repriced? And third, if the provider or patient pushes back, what should the payer do? It can range between what the payers call stand-on data, meaning that it doesn't move at all to increase payments on one end, to making fairly drastic concessions to eliminate patient noise on the other end. This is a spectrum, and employers can choose to be where they want to be along this range. A final side point, if you will, about the irony of this, is that whatever the employer chooses, whether it's stand-on data or whether it's to make concessions, the vendor or insurance company has data to support that position. Next slide, please. The insurance companies outsource the implementation of these bill-by-bill minimization tactics to companies that specialize in helping payers reduce payments to providers, either through negotiation services or repricing services, or both. You may have heard of these companies. You may be familiar with these companies, the folks we've already talked about, like Multiplan, Viant, NCN, FairPay. This is just a small sampling of the companies that specialize in helping payers in this regard. Today, there are now well over 100 companies that assist payers with reducing out-of-network reimbursements to providers through these bill-by-bill minimization tactics, and it's costing providers literally billions of dollars per year. Next slide, please. Here are some of the headlines of from the websites of several of the vendors who work for health insurance companies, helping them reduce payments to providers along with the promises that they make. You see the quote in the upper left where they talk about not wanting to pay retail. You see the quote in the lower right where they talk about wanting to negotiate up from your costs, not down from your billed charges. Next slide, please. These vendors, these companies, they hire senior professionals who used to work for providers, and they know a lot about you. They have databases that track every past negotiation, so when an out-of-network bill is input, a screen pops up with the names, titles, and phone numbers of the folks in your business office. So for example, that screen might say, don't go to Mary, she'll only give a 30% discount. Go to Bill, he'll give a 40% discount. Next slide, please. So let me switch gears here and talk about the 8 keys to increasing out-of-network reimbursement. Next slide. The first key is time and persistence. Handling out-of-network bills is a time-consuming task that requires persistence. On any given case, you may need to be writing multiple letters, you may be making multiple calls a day, and you just have to be persistent in order to make this work. Next slide, please. The second key, sort of related to the first key, is focus. Your team might be pulled in many directions. Dealing with out-of-network issues is just one of a dozen or dozens of tasks your team might be juggling in any given day. But you have to maintain your focus on executing your out-of-network strategy in order for it to be successful. Next slide, please. The third key is you got to know what you're doing. There's a lot of specialized knowledge around out-of-network reimbursements that you need to have in order to be successful. Next slide, please. And here we've listed several of those types of things, types of expertise that you need, such as being able to really read and understand an EOB, have a workable assignment of benefits, make sure that you document your calls with the insurance companies and record reference numbers. There's just a few of the things in the bag of tricks, if you will, that you need to have in order to deal with this issue. Next slide, please. So let's talk about what it means to be effectively reading an EOB. By design, EOBs are difficult to decipher, which when coupled with the fact that staff can be very busy, means they're often not read correctly. As an example, I've inserted a couple of actual EOBs. These are remark codes from EOBs that show how confusing it can be. So you have the first one here, the first example, which says, payment of benefits has been made in accordance with the terms of the managed care system. So reading this statement might lead one to believe that it was paid at in-network benefits in accordance with the managed care system, right? No. In reality, it's saying that the managed care system allows for out-of-network, and it has been processed based on those out-of-network benefits. Are you confident that the folks in your office would lead to that conclusion? The second EOB language here, the remark code, charge exceeds fee schedule / maximum allowable or contracted / legislated fee arrangement. This is a catch-all. It gives 4 different and distinct options as to how this claim was processed. Which one would your staff pick? And how would you proceed to question it? Next slide, please. Along similar lines with respect to your assignment of benefits, do you have a well-drafted AOB? We're not offering legal advice here, of course, but here are a few items you may want to ensure that are included. Does your AOB assign the right to appeal and the right to receive relevant documentation, as well as other rights of the patient? Does it refer to the provider as the patient's authorized representative? Does it properly reference ERISA and a full and fair review of claims? If your AOB is inadequate, and candidly, when we see the AOBs of many of our clients, they are inadequate, it's another roadblock that the payers use to stop you from getting reimbursed on your out-of-network bills. Next slide, please. So the next point is to document all calls. Do you document all calls with the payer, whether it has to do with checking benefits, pre-authorization, etc.? While sometimes payers will tell you expressly that you cannot depend on what's said in these calls, you are best off ensuring that both parties understand what was said and the provider has a record of what was said. Next is recording the reference numbers of calls with the insurance companies. Do you have a practice of doing that? Recording those calls, recording the reference numbers from those calls. It's important to record these reference numbers again in case there's a dispute later as to what was said. Next slide, please. A fourth key is to obtain the data to prove that the insurance company's payments were inadequate. You need to be able to argue that the insurance company's reimbursement levels are inconsistent with your own history with that payer and preferably the history with other providers in the community. Next slide, please. Key 5. The 5th key is understanding payer-side incentives. What drives them from a financial point of view? What drives them from a customer point of view? You need to understand that in order to deal effectively with them. Next slide, please. And the best way, of course, to understand payer-side incentives is to have folks on your team that come from those organizations that understand how they work and how they operate. Next slide, please. Key 6. The 6th key is to have a rigorous appeal process for those bills that have been cut or underpaid due to UCR repricing. I'll take you through at a high level our process on the next slide. Next slide, please. Now, appeals occur when a payer reprices a bill at a low amount and you're trying to re-engage the payer to get a second payment. From the insurance company's perspective, they're done. They made a determination of what was reasonable and customary. They made a payment based on that finding, and now it's up to you to get them to change their minds. This can be a labor-intensive process, again, hearkening back to keys 1 and 2. A labor-intensive process to appeal that underpayment and obtain a higher payment. Here are the steps in that process. Step 1, the initial intake. This is where you ensure you have the documentation necessary to handle the claim. You must have the UB, the EOB, the AOB, and any billing and collections notes. Step 2, payer verification. Contact the payer to verify the patient and bill information and obtain a verbal explanation for the basis of the reduction. Step 3, strategy development. Devise the appropriate strategy for this claim. This involves formulating the facts and arguments that are to be made to the payer. Of course, here at CollectRx, we use our CRXIS business intelligence engine to help in that process. And then step 4 is to engage with the payer. Engage with them and present the facts, present the arguments. And to be successful with appeals, you need to be able to make calls every day, write letters every day, escalate when necessary to entities like the state insurance commissions, for example. And once you fully present the information to the payer then will internally reconsider its decision, and typically at least several weeks will pass before the payer reaches a final decision. Step 5, settlement agreement and post-settlement follow-up. Not surprisingly, payers don't always pay on time and in the correct amount, so when you are successful getting additional payment, you need to follow up with the insurance company to make sure that you get paid. Next slide, please. Key 7. The 7th key is performing audits of your out-of-network activity to ensure that you're taking full advantage of the opportunities to increase your reimbursement. Our auditing process is set forth on the following slide. Of course, something you could mimic and handle yourselves if you'd like. Next slide, please. Oh, I'm sorry, that's the right slide. We've developed a process to analyze your past out-of-network activity and identify cases we can appeal. We use our data and analytics and expertise to identify cases with potentially recoverable underpayments and then turn them into significant revenue by appealing to the insurance company. Next slide, please. The process is very simple. It starts with running a report of out-of-network activity for the past 12 months. The client either runs a report themselves or we help them. We then will analyzing the report, focusing on finding cases to appeal, and using our professional judgment, data, and expertise, we then determine whether and to what extent to pursue a particular appeal. And if the provider, if the surgery center doesn't have time to pull the paperwork, we'll do it for them, either through payer portal access, remote system access, or even visiting on site if required. And then again, we use our proprietary processes to appeal to the insurance company to get additional payments for our customers, which frankly for many, and if not most of our customers, represents found money. Next slide, please. We can include a couple case studies just so you can see what kinds of results that these audits can do for you. First one here is a Pennsylvania-based surgical hospital that was in network with every payer basically except for Aetna. And as you can see, we brought them almost $250,000 on these cases in about a 4-month period. Next slide. We have another example here. This is from one of our clients in Texas, where we obtained over $200,000 in additional payments to this facility, again, in a very short time. Next slide, please. And key 8, the final key, if you will, is access to attorneys. Again, we have attorneys as part of our staff. We also have outside healthcare reimbursement attorneys. At times when it's necessary to escalate, you need to have those types of resources to turn to help you do so. Next slide, please. So here on the next slide, we have the 8 keys, if you will. I do want to talk for a moment about how we satisfy each of those keys. I've alluded to a couple of those already, but want to sort of take you through that. So again, key 1, time and persistence. Again, here at CollectRx, it's the only thing that we do, and we have the manpower and the time to do this on a full-time basis. Key 2, focus. While your team might be pulled in many directions, we're focused solely on increasing reimbursements on out-of-network bills on a case-by-case basis. It's all that we do. Next box. Key 3 is specialized out-of-network expertise. Part of our secret sauce is the depth of our knowledge on how out-of-network reimbursements work from the insurance company's perspective. Our team has held senior management positions with insurance companies and vendors like Aetna, United, Multiplan, and Viant. And, we handle over $1 billion in out-of-network bills each year, and our team knows who to speak with at each of the insurance companies and their vendors. We know how to get to senior personnel. We know how to get to the right folks who can help us get satisfactory results for our clients. Key 4 is comparable data. We have a large amount of comparable data from the 1,200 plus customers we service and use that data to poke holes in the arguments of the insurance companies and get higher payments for our customers. Key 5, we know payer side incentives. We know what motivates them financially. We know what motivates them from a customer standpoint, and we leverage that to get higher reimbursements for our customers. Key 6, the appeals process. We've already talked about needing to devote the resources to that process and to have a process in place that works. But the third sort of part of that is you need to know the nuances for how to handle these cases. It goes back to the expertise that we've been talking about. So, for example, we are very well aware of that sometimes it's important to know when to write. Sometimes it's best to call the payer. We know the arguments to make. We know the factors to consider, including who the payer is, who is the out-of-network vendor, how the charges compare to other similar providers in the geographic area, and what are the local managed care rates. That data points like that we use to put together the right approach for a given appeal that we're handling for our customers. It's also necessary to know when to escalate, when to file a first-level appeal versus a second-level appeal versus an external appeal, and when to escalate to other entities like the U.S. Department of Labor. Key 7, out-of-network audits. Went through that already. But basically, we have the time and expertise to perform the periodic audits of out-of-network activity we reviewed, and we look for those opportunities to gain additional revenue for our customers. And then finally, healthcare reimbursement attorneys. As I mentioned before, we have some on staff. We also have the ability to bring in outside healthcare reimbursement attorneys when necessary in a particular case. So in a nutshell, those are the keys to success as you think about how to get higher reimbursements on your out-of-network bills. Next slide, please. So having just spent the time on the first micro-level strategy, let me switch gears here and talk about the macro-level strategy, so-called global discount agreements. And what I'm going to talk about here are both third-party rental network agreements as well as what are called continuous discount agreements. Next slide, please. So what's a silent PPO or rental network agreement? It's a tactic used by an out-of-network insurance company to avoid paying higher out-of-network rates by utilizing the discounted rates of another insurance company, typically without the provider's knowledge. These agreements are signed not with the individual insurance company, but with a third party that contracts with a lot of different insurance companies. These are middlemen of sorts, bringing together payers and providers to participate in contracts that often are not favorable to the provider, and moreover, they're offered to insurance companies and networks that the provider doesn't even know about, the so-called silent PPO. They sound easy. With one contract, you ostensibly have a contract with all of the insurance companies signed up to the network, but what providers don't realize, and as we'll talk about momentarily, these agreements can be very detrimental from a provider reimbursement perspective. Next slide, please. So as a starting point, it's really important to understand who's the customer here with these agreements. To be clear, it's not the patient. It's not the provider. It is the insurance company. Go check out these companies' websites and you'll see it there. The reason this is important is you need to recognize that they're not there to serve you. They're there to serve the insurance companies. And they do this as a cost containment initiative, their words, for the payers. So if they're helping insurance companies save money, who is losing that money? Next slide, please. So while these sound attractive, they often have unintended consequences and should be closely scrutinized, whether it's you're deciding whether to enter into such an agreement or you're looking at your agreements now to see if you want to stay in them. So let me talk about some of those things that you really need to consider with respect to these agreements. To be clear, there's typically no patient steerage from these third-party rental network agreements. In a traditional managed care contract situation, you are essentially agreeing to a discount in exchange for the insurance company steering patients to you. Think of it like a volume discount. You agree to lower reimbursements in exchange for more patients, so that results in patient steerage. However, with these rental agreements, you're accepting a discount, but typically not seeing any additional patients as a result. Another point, not only do providers have no idea of the breadth of these agreements, many providers don't even know they've entered them. They were signed years ago by staff who's no longer at the facility, and the surgery center doesn't even know it. Another point, remember that there's no requirement by the insurance company to access the contract. In many instances, there's a web of these agreements, and the physician and the payer can selectively choose the contract with the most favorable rates. Finally, and related to that point, sometimes they're going to try to beat the contract. What does that mean? Well, since they don't have to access the contract, while there may be a contracted rate under one of these agreements, payers sometimes engage vendors in the negotiation bill minimization tactic we talked about earlier. So in other words, they'll engage their vendors to try to negotiate a rate that beats your contract. If they beat it, that's great. If they don't, the insurance company falls back on the contract. It's important your staff understands when this is happening. Next slide, please. Okay. So another question, another issue to consider. Are the reimbursement levels adequate? Since out-of-network reimbursements industry-wide are typically higher and sometimes much higher than contracted reimbursements, you have to analyze, do the reimbursement levels compare favorably to being out-of-network? Next point, are the reimbursement levels based on a percentage of billed charges or a percentage of allowed charges? Sometimes providers don't realize that the reimbursement levels are based as the percentage of the allowed charges, not the billed charges. This means that the payer takes a cut to arrive at the allowed amount, then applies that percentage to the lowered amount. So let's say it's a bill for $10,000. Some providers think that they have a 20% discount to the billed charges, where in fact it's the allowed amount. So what happens is the payer will take that $10,000 and they'll allow, let's say, 60% of it, and then the contract applies, and that's another 20% lower than that $6,000. So again, it's important that you realize whether the reimbursement levels in your particular agreement are based on the allowed amount or the billed charges. Next point, are the payers properly accessing the networks? Many providers receive payments at very low rates, with providers citing contracts they didn't even know existed. Pardon me. If you have a contract with a third-party network, do the parties have insurance? Do the patients have insurance cards with the logos displayed? Does the contract specify that payers are allowed to access the agreement? How do you know if a payer is part of the network? Does the contract specify that the changes in who can access the network must be communicated to you? Is there a provider directory? A lot of times you're flying blind as to which payers can access that network. Next slide, please. Some additional points. Are the payers applying in-network discounts with out-of-network benefits? Some agreements specify that out-of-network benefits can be applied, while other agreements are just silent on the issue. In either case, payers often apply in-network discounts and higher out-of-network deductibles and copays, which we call double dipping. Most providers just assume that in-network benefit levels are being applied and don't even realize what's actually happening. Does the agreement provide for multiple procedure reductions or other claim edits? A multiple procedure reduction, of course, occurs when a provider performs 2 or more procedures, and rather than reimburse all at 100%, the payers apply multiple procedure reductions whereby they reimburse the subsequent procedures at lower rates. Does your agreement allow that? Next point, is there a reference to a handbook? Oftentimes these agreements explicitly incorporate a handbook. In other words, the handbook and the language there literally becomes part of the contract. So for example, combining this point with the previous point with respect to multiple procedure reductions, we see situations where the agreement doesn't address those multiple procedure reductions, but the handbooks do, therefore making it part of the agreement. How many folks actually read the handbook prior to entering into the agreement? How many actually review it after changes are made? Very rare. The final point here is termination. Typically, these agreements are for 1-year periods and are subject to what's called an evergreen clause, meaning that they automatically renew unless terminated by either party. The catch here is the notice period to terminate. Sometimes the notice period is 180 days, meaning that you have to give 6 months notice just to terminate at the end of the contractual period. So if you only give 5 months notice, then the contract may not terminate for 17 months, the 5 month notice period plus a full 12-month year. In other words, on the following anniversary date. Next slide, please. So that's it for the third-party rental network agreements. Now let me talk about what I'd like to call a cousin of that third-party rental network, which is called the continuous discount agreement. This is another tactic used by the vendors for the insurance companies to lock you into reimbursement levels that are quite low. So the way this works is when you're signing a single case rate agreement on a negotiated case, there will be a box on that page. So in other words, as we were talking about before, the negotiation bill-by-bill minimization tactic, when you're negotiating that single case rate agreement, sometimes they have a box in the middle. It's usually pretty small type, and it says very simply by checking here, I agree to accept this level of reimbursement on claims in the future. What they've done by checking that box, and the providers don't even realize it, is that they've now agreed to accept those reimbursement levels going forward. And the problem is, a lot of times these agreements were signed by a staff member or even a temp years ago, and those personnel are no longer at the facility. And of course, because EOBs are difficult to read, many providers don't even realize these EOBs are even referencing these agreements. Now, the good news, or the better news about the continuous discount agreements, is with respect to termination. Unlike the third-party rental network agreements, which can have a very long termination provision, most continuous discount agreements can be terminated in 30 days. Next slide, please. So let me wrap up here with a word or two about outsourcing. Again, remember that the nation's largest payers, with their considerable resources, expertise, and data, generally speaking, outsource this function to companies that specialize in reducing out-of-network reimbursement. I liken the situation, as, again, I'm a former lawyer myself, I liken this to a person trying to decide whether they should represent themselves in a lawsuit or hire a lawyer. Sure, a layperson can file a lawsuit, layperson can represent themselves, but let's face it, a layperson doesn't understand the judicial system, doesn't know the law, doesn't know how to gather and present facts to support a legal argument, doesn't know about the judges themselves. So while a layperson can do it, is it really the best chance to be successful? Next slide, please. So if you're thinking about outsourcing, here are some evaluation criteria you may want to consider in making that decision. How does the firm fare against the 8 keys to success that we reviewed? Does the firm have the expertise, data, and resources? How do they charge for their services? Are fees success-based? Is there an upfront cost? Is there a big implementation? Is software or hardware required? Are there minimums? And can you cancel? Next slide, please. So if you were to put us through the test and decide to work with us, what could you expect? An increase in payments from insurance companies, a reduction in the need to collect large balances from patients. We know that collecting from patients is a difficult task, and getting more from the insurance company means less time chasing down patients. And finally, many of our best customers really see us as an extension of their business office. We're not replacing the billing office, but by letting us focus on out-of-network bills, it frees up time for them to focus on their in-network Medicare, Medicaid accounts, increasing revenue from these insurance companies. So next slide, please. So in sum, I hope you have a much better idea of the things that you can do to increase your out-of-network reimbursements and realize the financial gains of doing so. As I said at the outset, proper out-of-network reimbursement management is one of the only ways providers can improve financial performance. Thank you for your time. Let me open the floor for questions.
Thank you, John, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and will follow up on questions they do not have the opportunity to address. So the first question that we have here, I have a multi-plan contract, but the insurance company I'm out of network with isn't accessing it. What do I do?
Well, as we talked about during the presentation, the insurance companies aren't required to access any of these contracts. And basically what they do, speaking, what they do is they will enter into a web of contracts and use that web, as it were, to get the best rate, so to speak. And to do that, sometimes they will give it to one of their negotiation vendors and let the negotiation vendors see if they can negotiate a deal below the contract. So there's no really good way to know what's going to happen on a particular case.
Absolutely. Next question we have here. Is there a minimum size organization that you will work with, such as minimum billed revenue, et cetera?
No, we have customers that send us, dozens of bills a day. We have other customers that send us dozens of bills a year. We work on a bill-by-bill basis. Our fees are based on a bill-by-bill basis. So we're fine working with customers with low out-of-network activity and high out-of-network activity. It's the same to us.
Absolutely. Next question. Why is it advantageous to generate at least some of my revenue from out-of-network patients?
Well, as I said before, generally speaking, and this is generally speaking, but you're going to make more on your out-of-network reimbursements than you are on your in-network reimbursements. So having a strategy that includes at least a piece that's out-of-network is really prudent in terms of maximizing your overall reimbursement levels.
Definitely. Next question. You have addressed the payer aspects. What do you do with the patient's responsibility?
I'm sorry?
You have addressed the payer aspects. What do you do with the patient's responsibility?
Right. I mean, patient responsibility is subject to plan benefits. So whatever the benefits require in terms of deductibles, co-pays, co-insurance, et cetera, are still the patient's responsibility.
Definitely. Next question. How can I determine if I'm getting a benefit from my third-party rental agreement?
In order to determine whether you're getting a benefit, you're really going to have to engage in an EOB by EOB analysis. Otherwise, there's really no way to do it. Frankly, your account reps aren't really going to be able to help you that way. And what we find, frankly, is as a result that most providers that we talk to don't really have a good idea of how they are being reimbursed under those agreements. So, but if you can if you have the resources and time to do it, it's got to be done on an EOB by EOB basis.
Definitely. Next question. You mentioned the U.S. Department of Labor as a resource. Can you explain the relationship in increasing out-of-network reimbursement?
Yeah, well, you have appeal rights under certain types of cases to go what's called EBSA, which is part of the Department of Labor. It's a source for you to file appeals, again, challenging bills that have been repriced at low levels, the UCR repricings that we talked about before.
Definitely. Next question. Do the third-party rental contracts apply in situations where there's a fee schedule, such as workers' compensation or auto?
Yes, those agreements will apply unless there's a specific provision in the agreement that says they don't apply. Usually they do. I mean, again, going back to sort of the theme here, that the payers want the flexibility to reimburse those cases at whatever rates they want. So from their perspective, they'd rather have it in the agreement and have that as one of their options.
Definitely. Next question. Do I need prior authorization for out-of-network cases?
If the plan documents require that you have that type of authorization, then it is required. If the plan documents don't require it, then it's not.
Definitely. Next question. In these agreements, am I paid by the network?
No. I assume you're talking about the third-party rental network agreements. No. You're paid by the insurance company, and that actually creates another sort of layer of confusion, if you will, because you're not, when you are, the contract is with the third-party rental network company, whereas you're getting paid by the insurance company. If there's a problem with the payment or your relationship, if you will, isn't with the source, it's with the middleman. So it can create some complications in that kind of situation. But no, payment is being made by that insurance company.
Definitely. Next question. Do we send you the claim first to bounce off your database to avoid carriers paying UCR?
No, that's not the way it works. The way it works is the provider will send that bill to the insurance company. The insurance company will decide whether to reprice it or to engage in the negotiation. And if they engage in the negotiation, we get that case from our client to work, and that's when we run it through our databases. Or if that case has been repriced and it's a candidate to appeal, as part of the appeals process, we run it through our database. So no, it doesn't happen at the up front. It happens after the payer takes action, if you will. It's part of our processes in handling the case.
Absolutely. Next question. You mentioned earlier that insurance companies sometimes retain their vendors to try to beat the contracted rate. How does this work?
So basically what will happen here is the insurance company will give the bill to the vendor and will specify a certain level that the vendor has to, quote, beat in order to be authorized to get a deal done. Maybe, let's say, 75% the bill charges. And then the vendor will engage in a negotiation with that provider and try to do better than the 75%. And if they can't, then they're not allowed to do the deal. Now, the vendor, to be clear, doesn't necessarily even know that there is a contract in place. It's really done from the payer side. But, they have that sort of stipulated level they have to beat in order to do a deal.
Definitely. Next question. I receive faxes from these insurance company vendors asking me to negotiate a discount on cases, and my policy has been to throw those away. Is that a good approach?
No, it's not. If you don't negotiate, then that bill is going to be repriced, and the majority of the time, not all the time, but the majority of the time, it's going to be repriced at much lower amounts. The better approach is to negotiate, even if that just means accepting the proposal that comes in the door. Of course, here at CollectRx, we can do a lot better than that.
Absolutely. Next question. I have cases where I'm out of network with the same insurance company with the same procedure, and yet I'm reimbursed at very different amounts. How can that be?
Yeah, this is a question we get asked from time to time, and the key is what I was talking about during the presentation in terms of how out-of-network bills are processed and the role of the employer groups in setting those dials up or down in terms of how the cases will be negotiated and at what rates. So, essentially it's not the insurance company that drives the determination of what's reasonable and customary. Rather, that decision is really controlled at the employer group level. And, they're determining not only what the out-of-network benefit should be, but what the reasonable and customary amount should be on a given case.
Absolutely. I want to again thank our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.